Everybody? Okay. So I'll talk to you about challenges of persistent hypercalcemia that happen post-surgery. And the objective is to understand the challenges, and I'll share with you a case that I've been handling, it's yet not completed, I've been dealing with for the past almost 10 years in Qatar. And we'll discuss some causes and talk about prevention and management option. So this is share with you the case. This is a patient who I've seen in 2013. He is a 53-year-old man. He's German, working in Qatar. And he has hypercalcemia, and he has this past medical history. So in 2001, he had diagnosed primary hyperpara in Germany. He had surgery, and right upper parathyroid adenoma here was identified and was removed. And at the time, he had normalization of calcium and PTH lasted 6 years. And he had recurrence at the time he was working in the UK. So they did there, they found, identified this parathyroid, they didn't identify the other, they removed it. And they had, the patient had normal histology and hypercalcemia persisted. So 2 years later, calcium fluctuating, he got another surgeon who did extensive bilateral dissection with venous sampling, so that the gradient, but could not identify the adenoma. They tried to start this from here, they cut through here, and by doing that, they injured one of the laryngeal nerve. The left one was injured here. And the patient lost voice. He need to have a second surgery by a neurosurgeon, and eventually he recovered some voice. So when I see him, he has some hoarseness. And his hypercalcemia persisted. So he had 3 surgery, 2 parathyroid removed, and the other were not identified, and he has left laryngeal nerve already injury. Hypercalcemia persisted when he came to see me, and so he had remaining, perhaps the other are not found, so what do I do? So just to give you an example, that's his fluctuation. So I treated him with calcium agonist. I'll tell you more about that. But so just show you here, this is from electronic medical records. That's from the time when I've seen him. That's at the same time when we implemented electronic medical record. And you see here 4 episodes of severe hypercalcemia, that is phosphorus, and that's his parathyroid hormone can go up to many hundred here, so almost 800 and 700 and so on. So when I've seen him, so I started him on cinacalcet, 30 TID, and then he became very nicely stable for all that time until he came in with severe hypercalcemia. So at the time here, kidney stone developed, and he needed to have his kidney stone fragmented, removed, and then he get multiple admission for hypercalcemia that was treated with IV, and bisphosphonate, cinacalcet increased, and then he's been stable also for 6 years. So, okay. And so of course I see him every 3 to 6 months. And then he had multiple episodes here, and this episode, were very, every time he get into admission, a lot of symptoms, lethargy, fatigue, agitation, and because of concern about his renal function, I'll tell you more about it, we started treating him with denosumab, and we escalated cinacalcet to 90 TID to KID during the episodes, then we cut it down later on to 90 TID. So example, this is one of his hypercalcemic episodes that I showed you. This is in around February 2023. This is, I think, this one. Yeah. And so he was traveling. He did not have enough cinacalcet, so he decided to save on them. So he started using them, like 30 TID. And when he came to Qatar, his calcium was very high. And so he got an IV fluid. And then eventually we had to, he was discharged, came back again a few days with severe hypercalcemia. And so here we decided to escalate his cinacalcet to QID, gave him denosumab, and then calcium normalized, and he was discharged. This is another episode, similar thing happened, we repeated almost the same thing. So essentially he had this episode, and during this episode, what you see here, plasma creatinine is going up, and so the concern is now we're having somebody with chronic, persistent, recurrent hypercalcemia, and creatinine is rising. So, of course, during that time, we did not consider repeated surgery because he was stable for a long time. But when he had the first episode of hypercalcemia, I spoke with him. He doesn't want to do surgery. He said, well, how we consider surgery now? You may have risk in your kidney. And so he said, yes. Then we started doing new localization. So Dr. Ansari, a few hours ago, talked to you about localization, which attempted. So we did multiple ultrasound, multiple system EB. All were negative during that time. So because he was stable, we forgot about it. But on the one before last episode, he had actually multiple admission and creatinine was worsening. So, and at the time we got fluorine 80 choline in our system. So we thought, let's do a new localization study. And this time this is a MEB scan. It seemed to be somehow positive. You can see it here. This is, so impressions, this is the first time MEB scan show positivity. And this is, you can look, this is a 3D image of the choline, fluorine 80 choline scan. And what you see here, it's 3 potential lesions, okay? And you can see 3 potential lesions here, 1 anterior, 1 correspond to the superior and inferior from the right side. And so we proposed to have surgery for this, so I can give you first. So the ultrasound also identified right posterior and left lower anterior hypoechoic lesions. The left lower anterior here doesn't correspond to anything because it's not in the right place, because it's completely anteriorly. And is not in the right place for the parathyroid, but it is visible on ultrasound and visible on the scan. And we thought there's potential adenoma there, and we saw this uptake from here to here. We thought there might be parathyromatoses, and so essentially we discussed with him potentially to have right hemithyroidectomy and removal of this lesion, but we also he very much concerned if he lose the second retrolaryngeal nerve, he will become permanent CAS, tracheostomy, and he will lose voice and so on. So we have a lot of hesitation, and that was the discussion, and he did not have the surgery, of course. So just give you, he's thinking about it to find the right surgery. In fact, he went to the US. He went to a center specialized in parathyroid. They talked to him. Also, he was scared. They didn't do the surgery. He came back. So we currently have him with good localization, but no surgery, still on medical management. So to give you background, of course, so we have the parathyroid, we have 4 parathyroid that develop from 3rd and 4th pouch. The 4th pouch actually give the upper parathyroid, where the 3rd move much longer and give the lower one and give the thymus. And so during this migration, a piece may be left out, and that appears an ectopic parathyroid. Two parathyroid may fuse, or it may go all the way in the thymus or in the chest. So if you were to do, if you are looking at that section here, you will see this is anteriorly, you see the parathyroid and the retrolaryngeal nerve very close to each other, and same thing here for the inferior. And that's why we need to have a specialized center and surgical skill to deal with the parathyroid. This is a review published in 23 in this surgical journal, and essentially comparing cause of primary hyperparathyroidism when you first diagnose them, and in those who have recurrent. So still in recurrent hyperparathyroidism, the bulk of them are single adenoma. And that's why surgery is a good option if you have not the case that I shared with you. So somebody who has first surgery and you have a second surgery and good localization and good surgeons, that's become a good option. However, the hyperplasia, originally around 5%, become almost close to 30%, and that's a problem in the recurrent. And a carcinoma is not as much, and parathyromatoses is not as much. So what predicts failure of initial surgery, which leads to persistent recurrent hyperparathyroidism? If we have inadequate experience and or surgical technique, or we have a center who doesn't do a lot of this surgery. So essentially in this review, we need to have more than 50 surgery a year by the surgeon and the location. We need, because the surgeon may not recognize the pathological gland and not performing bilateral cervical exploration and not good collaboration to identify PTH reduction during operation and insufficient cooperation between pathology and laboratory. Ambiguous imaging result, of course, that's important because the surgeon will do surgery without knowing where the gland. But also there are patients related if the patient is elderly and if the primary disease is hyperplasia or double adenoma. The likelihood of having recurrence much higher than when we have single adenoma. Or if the patients really have a bad general health, if this is anesthesia score, is somebody with, score 3 is really advanced disease, score 4 and 5 is somebody is close to this. So what option we have? We have a repeat surgery option. However, because anatomy is disturbed, the risk of complication is very high. And anatomy is disturbed, risk of not finding an adenoma is high. And we need to repeat all localization study looking for ectopic site. And if no adenoma is identified, then, but we identified some source, and chances, if we have good surgeon, to move in and remove all possible sources if the parathyroid hormone is high and calcium is high and patient having complication of this hypercalcemia. But if no source identified, we need to manage medically, repeat imaging until is identified and until we have an experienced surgeon. Medical management is using calcium receptor agonists, cinacalcet, as I described in our case, and escalate dose. In fact, we escalated up to 120 milligram 4 times a day during the episode, and it was tolerated, and I think it's possible to escalate. Patient, of course, if they have hyperparathyroidism, we need to predict the effect on bone and provide bisphosphonate to protect the bone. If patient may develop acute episode, they need to be managed with acute, like admission to acute medical unit or emergency department, give them fluid, and of course bisphosphonate And if eGFR is low, consider give denosumab. Maximize dose of cinacalcet, as I said, and I think this was my last slide. Okay, maximize the dose of cinacalcet during the acute episodes. They can dose it down later on. I'll stop there. Thank you.